Patients, you know, if they don't have that assimilation, depression starts to set in. They get isolated, they get no social interaction. Those that live in assisted living, that's why it's really important that they start taking part in bingo day or bridge and Tuesday afternoons or whatever activities they have all set up and planned. It helps keep some of that depression away from our patients. Where they're more likely to thrive, they'll eat, they'll become interactive. But depression does set in when we start to see, these patients start to see their families dying off or their friends dying off. Family members don't come and visit them as often as what they used to. They start losing that self-importance. They start losing themselves because they used to have a purpose. Now they feel like they don't have a purpose. Increased risk of suicide is very common in our elderly patients. And a lot of it comes down because they don't feel needed. They have multiple things going on. When we get to the final years in their life, you know, not only were they on that fixed income because Social Security is so wonderful nowadays, but their retirement is starting to run out. Just went through this with my dad. My dad's nearing the age of 90, and we were talking this, you know, about Christmas. He's like, I just can't do the large Christmas presents. And I'm like, you know, so what? He doesn't realize that we've torn up his check, you know, for how many years already that he gives us. But he's like, right now I realize I'm starting to run out of my retirement. It's like, well, we get it. We'll, you know, do what we can. But some of these patients don't have the family members. They don't have that to go ahead and pay for their assisted living home or their nursing home. Health costs are rising. Yeah, Medicare is great, but they have to have that supplemental insurance to cover additional costs, to cover medications. And so they struggle to make ends meet. Now, this is the Pulsar DNR form. One of the things that we brought up at our last advisory chief medical officer meeting was, who can give you orders? Can you go ahead and honor a power of attorney of health care? We went back and we actually looked at our policy. And our policy states that we can go ahead and, you know, withdraw care based on the words of a healthcare attorney as long as they have the paper with them. And it all comes down to that paper. So what we did is we tabled it until January. We have a lawyer involved right now. We're making sure that what we give to you guys to be able to accept so that you guys can do is on the up and up, because we want to make sure that you guys are well protected. Right now, this is the DNR form, or the PULSE form. This is the physician's orders for life-sustaining treatment. When we start taking a look at this, because, man, you look at this and you're thinking, there's a lot of words on there, and I've got to read this right now. But for you guys, first things to notice, there should be 5 signatures on it. If 5 signatures are not on this, this paper is null and void. Where am I talking? I'm talking down here. 1, we need the signature of the patient or the patient's representative. We need a witness to sign, so that's 2 signatures. Then we need the doctor's printed name, 3, doctor's signature, 4, and a date, 5. I'm sorry, not 5 signatures, but 5 items that need to be on there for this to be valid, okay? So that should be the first thing that you're looking at when you get these forms. Then for the most part, for you guys, the only place you're gonna look is box A. My patient does not have a pulse. They are laying on the living room floor. Do I do CPR or do I not do CPR? And that's what box A tells you right there. We used to tell you guys in the past that any family member could override this. Right now there's legislation out there that protects you guys for upholding this when a family member says, no, I want you to save my mom and dad. And you say, well, I've got this DNR. I'm sorry, this is what your mom wanted. And you uphold this form. This new legislation is going to go ahead and protect you. So we had this at our EMS forum meeting at the state last week that we talked about this. Where things get to be a little bit difficult for you guys is when the patient still has a pulse, because that's when we have to look at Section B here. Section B is what some of you guys might call a living will, or maybe some advanced directives. It's basically telling you guys what to do in the event that I can't tell you what I want. So with box 1 up there, listen, I can't tell you what I want. I'm not doing so well. I'm about ready to die. I want you to do everything you can to save me. I want you to give me oxygen, maybe intubate me, fluids, start IVs, give me medications, give me electricity if necessary. Run the whole thing. That's what I want you to do, as long as I have a pulse. Once I have my pulse stops, we refer back to B. In the second part here, it gets a little bit more gray. Well, I'll take that oxygen you're offering, but how you administer it, I only want it via nasal cannula. Don't intubate me. You can start an IV on me and give me fluids, but the only medications I want is antibiotics. Now, which we don't carry, but that's what it says. It even talks about being transported. Here, you know what, go ahead and take me to the hospital, but once they get to the hospital, I don't want to go to the ICU. We don't make that decision, but we can at least get them there. Make me comfortable. And then box 3 says, you know what, if I become a burden on my family, where my family cannot keep me comfortable where I'm at, fine, transfer me to the hospital, but just do whatever you guys can to make me comfortable. If I'm in pain, give me pain medicine. Don't start IVs on me. You know, you can give me a little oxygen by nasal cannula, but don't intubate me, don't give me CPAP, just make me comfortable. That's all it's saying. Anytime you guys are in box B and you have any questions about what should be done, contacting medical control is going to be really important because they're going to be able to guide you as far as what should be done for these patients. If you have an argument, son goes ahead and says, here's my mom's DNR. Daughter's like, no, you have to save my mom. This is where someone who has very good people skills, an officer, might be able to step in and take that daughter aside and say, listen, I understand, you know, I know that you love your mom, I know you want, but this is your mom's choice. Kind of talk to her. She more than likely will come around, but she kind of needs to have that conversation. She can't be like her brother and say, oh, here's the DNR, you know, because for whatever reason. But take the opportunity to go ahead and, you know, spend time talking to family members to make sure that they're doing okay. Backside here, just information. Now, what happens when you get on scene and they say, well, I'm the power of attorney of healthcare. Do you have paperwork? If they don't have paperwork, as of today, you cannot really honor anything that they request until they have paperwork, because that's what our policy states. Like I said, hopefully here in January we will have a new policy for you, new guidelines, something easier for you guys to understand, because we don't want to put you in those bad situations. What about the fact that you're on scene and you got your mom's sister, and you've got your oldest child, or the mom's oldest child, and we have a grandchild, and we've got a spouse. Who gets to say what happens to mom? Well, there is the Surrogate Act down here. And right on the bottom, it lists in order of authority. So if you've got the spouse, or the grandchild, and the child, and the sister, and everybody there, it starts off with the guardian. If not the guardian, the spouse or registered partner. Now, this is where things get to be a little bit more difficult. If they say partner, but it has to be of a registered civil union. Now, you're not going to ask them to pull out marriage license and paperwork and everything. I mean, obviously, if you ask them, hopefully they'll be honest with you at that point. Adult child parent, adult sibling, adult grandchild, close friend of the patient, and guardian of the state. That's the order that you can take, you know, the recommendations from. Okay? Bottom line though, you guys, it doesn't have to be on any salmon colored paper anymore. It doesn't even have to be the original anymore. Just make sure you have those 5 items. The idea of the pulse form is that this is supposed to be used United States wide, so everybody's using the same one. Does anybody have any questions on this? Everybody pretty good?
Can the power of attorney and witness be the same signature?
Yeah. Yeah. Absolutely.
Can that be a copy?
Yes, it can be a copy. As long as you can see in box D and E, those 5 items that I said need to be there, this is a valid form. How does this become void? If you look at it and you see the date here changed, scribbled out, if it's void, written void across the front of it, or if it's torn up, it's invalid. You know, and here's where it gets to be really bad. I mean, you want a whole bad show. Mom's on the floor, cardiac arrest, daughter and son don't agree, son has DNR, you're outside coming inside and the daughter grabs the DNR and rips it up in, you know, before you walk in the door. So son's like, well, here's her DNR, she just ripped it up. You can't verify it. It's nothing like a problem there, but contact medical control, they'll help you out, okay? All right, King Airways. Some of you guys may have noticed, have you guys seen the new Kings come through yet?
Yeah.
And you guys have seen the end, the nasal gastric tubes that are coming out with them? Or the gastric tubes? Yeah, well, evidently St. Francis was probably the only one in the region that went with the King tube that had the blocking of the base here with the balloon at the bottom. Everybody else went with this one here, which they had the gastric suction port in them. They do not make these anymore. The one on the far would be your left. They don't make those anymore, so all of the King tubes are going to have the port at the bottom open, which leads directly into the esophagus. Now, Adam did hand out at one of our medical officer meetings these gastric tubes. Okay, right there, looks very similar to that. That's fine, if you want to use those. I'll be honest with you, I'd like to see it just go to regular soft suction. They're a lot cheaper and they're easier to use and you can leave them continuously hooked up. But what this is doing is that on the back side of your King tube, there's a little opening there. And that's where you can go ahead and insert this gastric tube or soft suctioning down this tube. And it operates just like a regular gastric tube. You can decompress the stomach. If you have fluids that are coming back up, you can go ahead and suction them out. It's not going to put a lot of pressure on this end balloon that some of that fluid might leak around and end up being ventilated into the lungs. So they're also a little bit more curved than the other ones were. I mean, they go in pretty much the same. There's real no difference, but here we can go ahead and we have the gastric tubes. Currently, right now, I think that's what they're supplying in the bin, if necessary. If you don't have one, you can use the soft suction to drop down. You want to go ahead, this is a pretty tight fit for the purple one or the size 5. It fits in there, so you're probably going to have to lube it up a little bit to go ahead and be able to insert it down this port here. Okay. You have to go ahead and measure these. So you take the end right here, start at the tip of the xiphoid, go up to the ear, then take from the ear over to the nose area, and note on your gastric tube what mark you're at, and that's how far you want to insert it down into this port right there. So when you go ahead and you notice that there's marking on it, go ahead and insert it right to that mark. You want to keep it at, if you put it on the suction, 30 to 40, let me see, I think it's 30 to 40, yeah, 30 to 40 millimeters of mercury on low continuous suctioning for it, which is really nice because then it does decompress the stomach and it does go ahead and catch anything that might be coming back up from the stomach. Yep, connects right there. You can go ahead and Cap it off if you need to. But there's really no degree of difficulty to actually using this. Does anybody have any questions on it? This is actually a step in the right direction. I think it's great that we're finally, I like to even see on regular cardiac arrest, just regular NG tubes being put down, but for right now, this is what we're going to be using with our, with our King tubes. And again, that's, for those that just walked in, the new King tubes has this port here. And you're putting this NG tube down there. And that's the measuring on it, so. Questions? When you document, please make sure you put the information in your report. Whoops. Good?
Fantastic, good.
All right. I will get your quiz and I will get out of here for you.
Real quick, I don't know if anyone knows, but Adam Greenberg is no longer our EMS coordinator. Sarah is our new EMS coordinator with St. Francis Hospital this time. Adam moved to safety and
Emergency
emergency
management.
management within AMITA, because AMITA purchased Presence, is that correct?
Yeah, we are now Amita Health, no longer Presence, as of December 5th.
You're still going to try to teach our...
Yeah, more than likely I will still be out here for you.
Thank you. Good. Super. Congrats.
I think, yeah. So we just, to make it official, we just have to finalize some job description things, and as long as all that pans out, otherwise I go back to doing exactly what I was doing now, which is really no difference, so. But, hang on.
Donut.
Can I shut this off?
Yeah. This is the red button. Right there by the battery. Right there.